everyone to our mask ultrasound Zoom conference today, and we are so privileged to have a very young orthopedic surgeon from South Korea. And he is, he took all the exams that is available. He is certified in RMSK, certified in CIPS, certified in FIPP. He's also an osteopathic doctor, at the same time an orthopedic doctor. So anything that you would like him to take to get to pass the exam, he passed it. So I'm so privileged to invite him in this meeting today. And I am so thankful that he agreed. And his name is Dr. Yong Hyun Yoon. So I hope I pronounce it very well. I'm not good in Korean, but I know he has a lot of information to teach us today. But before we begin, let us just pause for a moment for a short prayer. Let's pray. Heavenly Father, we thank you for your goodness and your grace. We thank you for this life. We thank you for the opportunity that we can learn again from Dr. Yoon today about the ankle and its intervention. We thank you for gathering us together to kind of learn from each other, and that we can deliver this to our patients. Thank you for your goodness and your grace. In Jesus' name we pray. Amen. So today we are so grateful that Dr. Yong Hyun Yoon has agreed to teach us about the MSQS approach to the ankle. So Dr. Yoon, it's all yours now. So go ahead.
Okay. Good morning, my friend, Jim, and all of my friends. Thanks for invitation. I'm very, very glad to be here. My topic of today is ankle intervention and MSKUS approach to ankle. My name is Yong Hyun Yoon. Before I start, special thanks to Jim. He always did great things, established this nice event and nice other event, and he gave a nice lecture to us. And I always thanks to my mentors, Stanley and Tom Clark and other mentors. And remote mentors, I have never met them, Kevin Chang and Panjani. I learned many things from their articles and their presentation. And I'm always inspired from mentors, but special thanks to my patient. My patient always endure my procedure, and they recover from their injury and their pain. I always thanks to my patient. Oh, at first, let me introduce myself to you shortly. Yeah, this is my journey. I'm the MD and orthopedic surgeon, and I undertook conventional residency and fellowship. I enjoyed my residency and fellowship. After the residency and fellowship, I know that, surgery is a very important part of treatment, but if this is the only solution for patient, I don't know, I'm not sure. So my next path is orthopedic medicine and ultrasound and prolo and osteopathy. During my journey, I met many good friends, including Jim, and Liptop, and Stanley, and Tom Clark, and I learned many things from them. Yesterday, this photo is yesterday. I have a congenital flat foot, and I have many traumas to my foot. My metatarsal bone fractures and my navicular bone problems. So this ultrasound is included in my presentation. I inject to spring ligament and short plantar ligament and long plantar ligament. The day before, I injected the C0C1 for dizziness or the neck stiffness and other things. This is very fun. Everyday injection and enjoy my injection and enjoy my practice. Okay, why we use ultrasound to ankle? I introduced one article. This name of the article is this. ATFL is very most common injury site in ankle sprain, but isolated lateral ligament complex injury 20%, and ATFL only injury is 13%. The pattern of injury seems complex, and most patients appear to have more injuries. MRI, yeah, is very powerful tool for diagnosis. How about the ultrasound? This table is associated injuries with lateral ligament injury. You can identify all of things under the ultrasound: bone bruise, deltoid injury, and tendon injury, fracture, and osteochondral lesion, and syndesmosis injury also. Introduction to ligament of ankle. Ankle ligament is by far the most common type of ankle pathology. Traumatic inversion force is the typical mechanism of injury. Lateral ligaments are the most frequently torn. Among the components of the lateral collateral ligament complex, the anterior talofibular ligament. Lateral collateral ligament complex is composed of ATFL and CFL and PTFL. Normal ankle ligaments have a fibular ecotexture and are sharply marginated. Anisotropy can be seen with the ankle ligament. As with tendon imaging, this potential artifact is avoided by scanning with the ultrasound being perpendicular to the ligament. This is very important part. Injury severity and types. Injury severity is started from mild sprain and ended osseous abrasion fracture and major fracture. Mild sprain is noted as slight thickening or loss of normally fibular ecotexture. Partial tear, there is discontinuity of the ligament, and important part is remains taut with dynamic maneuver that place the ligament under tension. So if you check the ligament like under the ultrasound dynamic exam, partial tear will be seen. With complete tear, a hypoechoic gap is noted and the ligament fibers do not become taut with any maneuver. It's torn like that way. Osseous abrasion is my major part. Yes, microfracture. You can't identify the X-ray, and sometimes after 1 week or the 2 weeks, patient has a pain, but MRI, there's no fracture in MRI, but I always find very interesting fractures in the ultrasound. Osseous abrasion at the ligament attachment site denote a very severe ligament injury. Chronic tears that have undergone scarring may demonstrate thickening of the ligament, and ossification may also be an important part. ATFL is injured, the CFL should be carefully assessed because of sequential injury of the lateral ligament. So I introduced many biomechanical things to you guys because ATFL injury is not a simple injury. So you need to check the next step is CFL. And why do we need to check the AITFL? I'll give you the answer. This is my strategy to ankle joint. Ultrasound is cost efficient to MRI and unique capacity to allow evaluation during dynamic maneuver. Another advantages including the claustrophobia and pacemaker hardware. Yeah, they cannot do MRI and direct and real-time evaluation of the site of pain or symptoms with additional history immediately available. Flexibility in the field of view. If you want to see the another side, like this thing is congenital or the disease is from the traumatic. We don't know. We need to check the another ankle. So in the ultrasound world, okay, go to the contralateral side, and there is no magic angle artifact. Learning, but important thing and very hard to cover is learning curve. and operator dependency. We need to cover these things. This is my strategy. Number one is AITFL and go down parallel to the AITFL, and I found LFTCL. And then pivoting the probe to the ATFL, and I found out upper part and lower part. And then pivoting the probe more posteriorly and calcaneofibular ligament. And then probe go to the anterior or the distal. You can identify the bifurcated ligament, calcaneocuboidal part, and calcaneonavicular part. And posterior talofibular ligament is the last part. If you have an ATFL injury, so you need to differentiate this part, because this part and superior part and inferior part is the different. Superior part is the intra-articular structure, and inferior part is not the intra-articular structure. Because there are two ligament type, and there are two other things in the ligament, because ligament is one of the ligament is the thickening of the capsule, and other ligament is the cord-like type. So you know the Patterson, and he's the pro therapist. He said that if you do injection to the extra capsule and you got the stability, yes, he's perfectly right. But how about the intraarticular injection, and what's the meaning of the precise injection? Because inner side of the ligament is for the proprioception. Yeah, cartilage, there is no nerve innervation, but how about the inner side of the ligament? There is a nerve innervation, and outer side, okay, nerve innervation also. So you need to check those things together. And chronic stage biomechanical property is very important, and chronic ankle instability and micro instability, you need to check that. If you miss the micro instability, we will meet the disaster, like the ankle osteoarthritis and chronic ankle instability and osteochondral lesion, and very severe disease. And flat foot after trauma, other to acquire the flat foot. In my foot, I have a flat foot congenitally, and right foot after the fracture, my biomechanics is distorted. You need to know the cuboid syndrome. Cuboid syndrome is an important part of the trapart joint and navicular bone. Have you ever seen the article of the transverse arch of the in the Nature? 1 year or 3 years ago, my colleagues always they concentrate on the longitudinal arch. But nowadays, transverse arch is very important part. So that's why I focus on the cuboid and navicular bone. They only focus on the navicular bone for longitudinal arch, but you need to check the cuboid bone simultaneously for transverse arch. And last thing is very important subject, osteochondral lesion. Okay, this is the gross anatomy of the ankle joint. There are 3 ligaments in the first photo and only 3 ligaments in the second photo. Number 1, this ligament is AITFL, and number 2 is the basal ligament. Number 3 is ATFL. 4, 5, 6 is a posterior inferior tibiofibular ligament and intermalleolar ligament, and PTFL. This ligament is AITFL. AITFL is injured in cases of high ankle sprain. For example, main sinew injury. If you're suspicious main sinew injury, should check deltoid ligament, AITFL, and syndesmosis, and proximal tibiofibular joint also. This is the biomechanical stuff, so if you learn biomechanics, it will be fun. There is one of differential diagnosis point in this view, basal ligament. This is the AITFL, and this is the basal ligament. This is inferior to the AITFL, and Yes, sometimes ankle instability is disrupted and basal ligament impinged with a talus. The examiner holding the foot and moving it toward the external rotation and slight dorsiflexion of the ankle, and you can identify the dynamic exam. Okay. Oh, sorry. This is the AITFL bundle. Can you see there? This is the nerve. So if you injection to the AITFL, always check those things. So sometimes ligament is torn and nerve is adhesion to the ligament side, and patient has the CRPS like the symptom or the nerve symptom, paresthesia, and other symptoms. So always check this nerve together. And this is another example, AITFL old aversion fracture. Yesterday, I checked my patient's ankle, and she said that 3 or 5 years ago, I injured my ankle, but I don't have a symptom. But yesterday, I have an ankle pain. Yes, that's a very typical history. So check the ultrasound, you can identify this fracture. And this is the dynamic maneuver. And you can identify the hemarthrosis here. Blue, ligament is swollen, and joint stability is disrupted. Okay, once again. When the examination is performed by the single ultrasound operator, the patient is asked to gently press his heel toward the bed to stabilize the ankle post-stress maneuver. You can identify ligament problem here and just sprint. This is the acute stage. And why do I show AITFL first? This is my answer. In 1950, Lauge-Hansen described a classification system for ankle fractures on the basis of the mechanism of injury that included more than 95% of all ankle fractures and consisted of 2 criteria: the position of the foot, supination or the pronation. This is the supination and this is the pronation. And the direction of the deforming force, abduction, adduction, and external rotation. 13 subgroups were created according to these 2 factors. Injuries occur in predictable sequence, and important part, stages cannot be skipped. So if you find out the number 4 or the number 3, you need to check the number 1 and number 2 simultaneously. That's the important part. I introduced this classification to female doctors and pain doctors because this classification is very, very popular and very conventional to the orthopedic surgeon, but rehabilitation doctors and anesthesiologists, they don't know about that. In any sub-classification of the Lauge-Hansen system, findings from the previous stages are summed. Yes, most important part. So, and there is a ligament injury and a fracture and other things. So, if there is no fracture, but if you find out the deltoid ligament injury, you need to check those things. If you find out the low side or the spiral side fracture, after the fixation, patient has pain, you need to check those things together. That's the very important part. And 1 millimeter lateral talar shift, 42% contact surface problem is occurred, and then final step is osteoarthritis. 90 or the 95% of the arthritis is caused by the ankle joint trauma. ATFL, this ligament is most common injury part of the ankle. If this ligament is injured, you should check the CFL and bony problem like bony bruise, overjoint fracture, and osteochondral lesion. Concomitant bony bruise is 75%, fracture is 30%. Yes, it's true. And osteochondral lesion, almost 20%. You need to check that. Dynamically during plantar flexion and during inversion stress or anterior test, you can identify these things. Static image, you can't identify, oh, this something is weird, but dynamic exam, complete tear. And lateral talar process fracture can also be assessed when scanning the ATFL. There are two fascicles of the ATFL. Superior fascicle of the ATFL is a distinct anatomical structure, whereas the inferior ATFL fascicle and the CFL share some features being both isometric ligament, having a common fibular insertion. Superior ATFL fascicle is an interarticular ligament that will most probably not be able to heal after the rupture. So regenerative injection target is here because the interarticular structure is not healed well. And micro instability of the ankle is developed. In contrast to the chronic ankle instability, micro instability is an emerging concept, and the current proposed pathomechanism is a partial tear of the ATFL. This is affecting the superior fascicle of the ligament. And partial tear of the ATFL can affect the whole superior fascicle of the ligament. And this is the different facet, insertion site. Fibula side here and talus side here. And change it like this way. This is the superior fascicle, and pivoting your probe like this way, inferior side. So you can identify another insertion site of the ATFL. If the ankle, if you find out chronic ankle instability, please check the deltoid also. The incidence of the deltoid ligament injury was found to be 70% in patients who underwent lateral ligament surgery for chronic instability. But I think that in the surgery case, it's a very severe case and the chronic case. So I don't agree with this article 100%, but you need to check the deltoid ligament also. In the ankle sprain, ATFL injury incidence is 75%, and CFL injury is 41%. CFL started from fibula and attached to the calcaneus, and you can identify peroneal tendon above the CFL. Examine the dynamically during dorsiflexion with inversion. Peroneal tendons are located immediately superficial to CFL, but maybe my approach is something weird or something different from you guys. That's because I removed the fibula like this way, and I can identify the CFL fascicle very clearly, because CFL visualization is very difficult. Proximal attachment of the CFL may be limited because it's positioned deep to the lateral malleolus. So I changed my probe position, not like this way, like the way, so anterior to posteriorly. So change the probe position, anterior probe position like this way, and you can identify this fibular pattern clearly. And this dynamic maneuver is same thing. So you can identify all of the attachment site clearly. ATFL and CFL are connected by archiform fibers and forming a functional and anatomical entity that has been named the lateral fibulothalocalcaneal ligament complex. LFTCL complex is injured, classical ankle instability resulting. In addition, because of the presence of LFTCL complex, excellent results are observed. When an isolated repair of the ATFL is performed, ankle functional recovery is very well. There's no article of the visualization of the ankle visualization of the LFTCL, so this is my method, this is my suggestion. LFTCL is very important structure for stability. Not enough method to there. Patient sitting position and natural sitting position with knee extension. approved position for LTCL is parallel to AITFL and sliding down to cauda. Do not pivot your proof and check the talus, and then this is the talus, and then you can identify those bundle of ligament. There are 3 bundles of ligament, 1, 2, 3, and this ligament is the superior fiber, and this ligament is the inferior fiber of the ATFL, and this is the CFL. Sometimes I found out impingement in here. So this is the dynamic exam of the FTCL. Yes, tail side. If you check this way, you can identify the tail side here. Dynamic exam is almost the same position and eversion stressed by the examiner, like the eversion and ligament tear. You can check the FTCL by this way. And this is my favorite part, another favorite part, bifurcated ligament. Based on the literature, the involvement of the metatarsal ligament is reported to occur in 5 to 33% of the ankle inversion injuries, mainly affecting the supporting ligaments of the talo-calcaneonavicular and calcaneocuboid joint. Bifurcated ligament bridges the 2 joints and plays a role in their mechanical coupling. Bifurcated ligament is a strong band consisting of the combination of the 2 components. One component is a CC and another component is the CN part. This provides mechanical support to the talonavicular and CC joint respectively. I found many fractures in here. Other hospital orthopedic surgeons recommend the ligament reconstruction, modified Brostrom operation to patients who have ankle instability. I found these things, over the 20 or the 30 cases. Yeah. And patient has a pain after the modified Brostrom. I found those things, yes, after the operation. After shockwave or after the regenerative injection, pain is gone. Before the surgery, you need to check those things. And this part is not visualized in MRI. You need to check the CT or the ultrasound dynamic maneuver. This is a very, very important part. And dynamic maneuver method like this way. This is the calcaneus and this is the cuboid. And this ligament is not attached to the just proximal side. This ligament is attached to the distal to the cuboid. Important. So you need to check the whole of things. Sometimes I found fracture here because this ligament is not taut. If this ligament is not taut and calcaneus cuboid impinge like this way, and then you got the fracture in here. If you found the hemarthrosis here, yeah, please check all of the things. Fracture, ligament injury, and so on. Bifurcated ligament is for mechanical stability. It's the 2 part. You can check this ligament dynamically. Another part is that this is the calcaneus anterior process, and this is the cuboid. My favorite injection site is the calcaneocuboid joint. It's connected by the bifurcated ligament and dorsal CC ligament. My favorite injection site is a CC joint and bifurcated ligament. This patient has subtalar joint arthritis after the calcaneus fracture 20 or 30 years ago. Orthopedic surgeon, they never do anything to the CC joint. Eye injection to the CC joint and subtalar joint posterior and anterior and other things. Patient pain is relieved 70 to 80%. Do not miss this magic site. CC joint, one of the articles said that the CC joint is another part of the subtalar joint. This is injection. Out of plane and ankle joint. CC joint is distorted like this way, and this ligament is very thick. And synovial problem is here. So injection to here, and joint is widened. Patient feel, oh, my hardest or my immobile part is mobile. Yeah, they say that. And non-union part is, I always recommend the shockwave, but this arthritic part or the ligament part, I recommend RIT, regenerative injection therapy. If there is a fracture, there is a ligament injury and joint deformation. And another part of the bifurcated ligament, calcaneonavicular part. This ligament is coming from calcaneus anterior process medial side to navicular bone lateral side. This broad ligament is not easily identified, but if you find out this neurovascular bundle, and this is a calcaneus and this is a navicular, and you can identify that this nice bundle. My favorite injection part is the CC joint and bifurcated ligament of the CC part, and but I always check the CM part also. So ligament is coming from the calcaneus anterior process and go out like this way. There are several ligaments in posterior ankle, PITFL and PTFL, and intermalleolar ligament. This article is written by Kevin Chang. I know that the PITFL is previously, but I do not differentiate the superficial part and deep part. Just the injection to there. And intermalleolar ligaments, actually, people, I read this article, I do not inject. I just inject the PITFL and PTFL like this way. So PITFL is composed of the superficial and deep component. Superficial part is originated from the posterior edge of the lateral malleolus and cross superior-medially to the posterior tubercle tibia. And deep part is just deep to the superficial part. And PTFL is an important part of the ankle stability. Lauge-Hansen classification, number one injury part is AITFL, and go to the lateral malleolus and PITFL. And ankle instability is composed of the ATFL, and then go to the GFL, FTCL, and then go to the PTFL. So after the injection to the ATFL or the FTCL, so if there is ankle instability or something weird or giving a symptom, you need to check the PTFL. Deep portion of the PITFL provides 33%, and PTFL is it's a 33% to the ankle instability. So you need to check the following things: the posterior part after the anterior intervention. And next part is the plantar foot. I have only 15 minutes. Okay, speed up. Okay, ligament of the plantar foot is spring ligament and short plantar ligament and long plantar ligament. Spring ligament is composed of the superomedial part and medial plantar part and inferior plantar component. It's initially considered to be elastic, acting as a spring. But nowadays, this is not true. Histologic studies reveal that the spring ligament is purely collagenous without elastic fiber. Despite this, the term is not changed. Isolated spring ligament injury is uncommon and can be found in 17% of cases with some degree of deformity secondary to the tibialis posterior tendon problem. Spring ligament injury is more common at the superomedial portion, so always concentrate on this part. Or if you find out the acquired adult flat foot, you need to injection to here or check the here. Inferior plantar part component is I'm sorry. This is the superomedial component, and this is the medial plantar and inferior plantar component. superior medial part is starting from the substantial tali and to the navicular bone, and this supports the talus like this way. So if your talus problem or the ankle joint deformity, like there's no arch, longitudinal arch, and you need to check the spring ligament. And another part is the medial plantar component and inferior plantar component. If you see the calcaneus like this way, its angle is changed, and navicular bone formation is changing. So if you if you check the spring ligament like this way, superior medial part and medial plantar part, inferior plantar part, and injection to there. Okay, this is the dynamic examination of the spring ligament. This is calcaneus and talus navicular bone, and there's fluid, and there's instability. This is my foot. And tendinosis and ligament problem. So I always wear orthosis to my shoes. Okay, next step is a long plantar ligament. Long plantar ligament originates from the plantar surface between the calcaneal tuberosity and anterior calcaneal tubercle. It attached to the metatarsal base, cuboid tuberosity, and plantar surface of the cuboid. Peroneus longus tendon crossing anterior to the cuboid tuberosity can serve an important landmark. And this is the calcaneus, and this is cuboid, and this is the fifth metatarsal bone. You can identify this ligament clearly. And short plantar ligament is on the side. And this is the cuboid just medial to the cuboid tubercle. And this side is more medial to the cuboid tubercle. You can identify the short plantar ligament. Short plantar ligament and long plantar ligament is a support to the cuboid. So if you find out the cuboid syndrome or the post-traumatic flat foot, so you need to check those things, ligament dynamically. This is the dynamic exam of the short plantar ligament. Your proof position to the plantar side and calcaneus, and check the calcaneus and cuboid, and spring ligament is checked dynamically like this way, plantar flexion and dorsiflexion, and stress to the your ankle. If after the dynamic examination, if you find a problem of a ligament or wanted to treat cuboid syndrome, injection to there under the ultrasound, you can injection to all of things together, long plantar ligament and short plantar ligament, and this joint together. Chronic ankle instability or the adult acquired flat foot problem, you need to treat all of things together. Okay, this is the injection. Landmark is the cuboid tuberosity. Identify the cuboid tuberosity and calcaneus and fifth metatarsal bone. Okay, again, we can identify all of things longitudinally. And injection point is this is the injection. Injection point is just proximal to the navicular bone, and identify your needle path and go to this way. This is the cuboid tubercle, and injection to here, and pivoting the probe, and needle go this way, and then injection to the joint area, and more plantar side. This is the short plantar ligament part, and more posterior, pivoting the probe more posterior. So I touch this side for long plantar ligaments. So you can identify the whole of things together in the ultrasound. Short plantar ligament, and long plantar ligament, and joint together. Subtalar joint is another interesting part. Subtalar joint consists of two articulations with separate synovial sheaths. First is between the posterior facet of the talus and calcaneus. This is separated from the second sheath by the sinus tarsi. A circle is formed between the posterior and medial facet of the talus and calcaneus respectively, and filled with the strong talocalcaneal interosseous ligament. Second articulation is made up of anterior and medial facet of the calcaneus and talus and talar head, navicular bone, and the cartilaginous surface of the spring ligament. Important part is the spring ligament has some cartilaginous surface. Anatomically made up of two separate joint capsules, these articulations do not move independently. It's one of the set. Talonavicular joint shares a synovial sheath with the anterior and middle facet of the calcaneus. But sometimes if you injection to the talonavicular joint, your injectate do not go to the anterior or the medial facet. You need to check that. Posterior contact surface wide and peak contact process are very big. My first target of the chronic ankle instability is subtalar joint for compensation. Because instability and variation of the subtalar joint morphology contribute to failure in the treatment of ankle joint stability. So if you inject into the subtalar joint, you can get the 30% to 60% of the pain relief, yes, immediately. That's why subtalar joint compensation of ankle joint is the important part. Progression of ankle joint osteoarthritis might be decelerated if the subtalar joint configuration allows for compensation. So do not miss the subtalar joint. This is the subtalar joint injection. This is the CFL, and this is the peroneus. My injection injected to go there. Posterior subtalar joint injection. This is the another side. This is the calcaneus anterior process, and this is the navicular. I injection to the CC joint, and then I go to the talonavicular joint, but injectate do not go there. So I changed my needle path to like this way. Just medial to the calcaneus anterior process and proximal to the navicular side, and injection here. And joint is ballooning up like this way. And I inject my iodine contrast to there. So can you see there? This is the middle facet. This is the middle facet of the calcaneal joint. And this is my another favorite subject, microfracture. Microfracture is the most important part in my practice. If the patient have gross displaced fracture and instability, recommend surgery. But you suspicious fracture, but not identified in the X-ray and ultrasound, you should check that dynamically. Can you see there? This is the joint, and one of the tendon attachment site is widened or the separated. This is the old case. After the 2 months or 3 months later, patient came to my office, and patient has 3 months ago I checked the X-ray and ultrasound. There is no fracture, but I have still pain. I have still pain in here. So check the all of things dynamically. Another thing is okay. I can show you another interesting subject. This is the calcaneus. This is the ATFL attachment site. Can you see there? Periosteal swelling, and I found a fracture in here. Other things is a complete rupture of the ATFL. How can you confirm the diagnosis? My suggestion is dynamic exam. Another thing is injection. I injection to there, and fluid leakage to all of the space. So complete ligament rupture was seen in here. Maybe you guys understand my ultrasound. This is the talus, and this is the ligament complex. This is the anterior. This is the posterior, lateral to posterior side. So this is the normal side, and ligament is consists of the 3 bundles. And this ligament is teared, and this ligament is teared, and something is weird in here. So always check the talus anterior and lateral and medially simultaneously. My treatment option is like this way: injection, prolo, hydrodissection, PRP, and stem cell. My number one is the prolotherapy. Prolo means proliferation. Over the 95% of the ankle osteoarthritis is caused by trauma, and ankle is weight-bearing joint. In this situation, stability is the most important part of the treatment. Cartilage is the second issue. Hydrodissection. I meet many cases of ankle stiffness during the rehabilitation period or after the prolo. At that moment, I checked the ultrasound and I found many adhesion of the small nerve particle to the ligament. Or sometimes I found neuroma or nerve gliding problems around the ligament. So some patients are diagnosed with CRPS, but after the hydrodissection, pain is gone. So you need to check this ligament and nerve very delicately. Number 3 is PRP. I use PRP is for special case because money and pain problem like the problem. For example, osteochondral lesions or cartilage damage and mild osteoarthritis. Number 4 is stem cell. I use this for severe arthritis. Hip and knee joint arthroplasty are well developed and long-term outcome is very good. But ankle arthroplasty is still controversial. I strongly recommend stem cell treatment to severe ankle osteoarthritis before operation. First step is prolo, second step is PRP, and stem cell is the last option before the surgery. And other things, I don't have enough time, so other things later. Yes, and when do you recommend prolotherapy to patients? This is my answer: Brighton test. Like this way, hyperextension of the fifth finger, and your thumb is like this way, and your elbow and your knee joint is hyperextension, and your palm to the bottom. This score is 2, 2, 2, 2, and 1. 9. Score 9 is up to 9, and over the score 4 you have the laxity. I recommend prolo to the patient and other nutrition also. Oh, my mission in Creta, my great friend, Stepan Cavallino, and maybe where is Ligia? Yes, maybe there is Ligia also. Okay, PRP, the process prolo to osteochondral lesion. This article is published in 2019. Osteochondral lesion of talus is one of the most common problems in ankle, and osteochondral lesion is caused by instability. There are 2 types of osteochondral lesions. 57% is medial type and 43% is lateral type. Lateral type is anterior to middle and wafer shape, very shallow. Medial type is middle to posterior and cup shape. This article injection was done under the ultrasound. Posterolateral type is posterolateral approach. Like that. Oh, this is my patient case. First visit 2018. I found that the fracture in here. Okay. This is the ATFL, and ATFL laxity shares the chronic ankle instability problem with acute sprain. So I found out pressure in here and hematolosis. There's nothing in here. This is the first visit. And second visit is this is a long-term follow-up visit. It's 2019 August. I found out the osteochondral lesion in here. And under the ultrasound, I found out this osteochondral lesion and periosteal swelling. Our last follow-up X-ray is this. Osteochondral lesion is recovered, and this is I checked. This X-ray is 2 years later after initial trauma. Our range of movement is intact. There is no sign and symptoms, no tender point. There are many options to osteochondral lesion treatment, from conservative treatment to the surgery. I strongly recommend conservative treatment to the patient, and if pain is consistent, I change my method to the shockwave treatment or taping and other things, because OCH, or the allograft and stem cell surgery is very big surgery. It takes 2 or 3 hours, and their outcome is not good, because after the microfracture, you can get the cartridge, but that's not the hyaline cartridge, that's the fibro cartridge. And OCH, you need to remove your, or you need to graft your cartridge from the knee or the ankle non-weight bearing site. Problem is a non-weight bearing site cartridge and the weight bearing cartridge composed is a different. So after the OCH operation, patient, pain go away, but several years later, sunken down like this way. This is a stem cell. I use nanopad to the ankle osteoarthritis. This case is treated her ankle by prolo and shockwave. She said 70% improved, but she was satisfied with previous treatment, but did more. I checked her fat composition. I found over the 40% of the fat in her body. I recommend nanofat treatment. Before the stem cell injection, I use D15% to here, and fluid is going out like this way, and then injection. Nanofat is a different type of stem cell. There's a particle, because SBF, or the bone marrow aspiration, is another part. This is not this nanopad is a different situation. It's a material for the nutrition for stem cell and other things. So PRP, or with stem cell, is very good result like this way, because the PRP is a nutrition or the vascularization to the stem cell site. Nanopad is almost the same. If you grind your fat mechanically and then injection to the ankle joint, that's the nanopad. Oh, time is over. Okay, my take-home message is number 1 is accurate diagnosis. Number 2, understanding the biomechanics and pathomechanism. Lauge-Hansen classification is step 1, step 2, step 3, step 4. If you find out the step 4, do not skip the 1 and 3. And appropriate use of the treatment tools, prolo, or the stem cell, or the PRP, and hydrodissection. Prolo is excellent. Hydrodissection is a very good tool. Stem cell, PRP is very, very important part, but not stem cell to the all of the case, not apply to the prolo to the all of the case. You need to know about the indication and contraindication, and make your large toolbox and pick up your tools. If you have any question, I'm sorry, too long.
Oh, Dr. Yoon, it's just okay. We're used to long lectures. We appreciate you for that very thorough discussion on the ankle and for other approaches using different regenerative treatments for the ankle. So it's really an excellent lecture on the ankle. So thank you very much. So for those of you who would like to ask questions, kindly raise your hand, or you can directly ask questions from Dr. Yon while he's still online. Any question? So maybe they understand everything that you have discussed, Dr. Yon. And
Doctor, I have a question.
Okay.
Yeah, okay. Doctor, I just have a question regarding the nano fat. We're not very familiar with the nano fat. So how long do you process it, and where do you get that from? Is that prepared prior to injection and things? Just an overview, Dr. Yoon. Thank you.
Nanopad. Nanopad is another version of the adipose stem cell. So if you want, like this way. Oh yes, okay. Nanopad is another version of the stem cell, and this is included to the adipose stem cell. And if you aspirate if you liposuction to the abdominal fat or your body fat, all of the space, actually it's okay. Or your belly is okay, and your thigh is okay, and then mechanically grind your fat. This is a very complicated. This is very complicated procedure. So mechanically, like the shaver knife, and going like this way, mix like this way, and then you can get the stem cell from the fat. If this is another technique, this is another long lecture. Yeah.
Yeah, maybe what is Dr. Pash is asking is whether you're using enzymes to process that.
No.
Or you just micronize it.
Yes.
Okay. So
mechanically, yeah.
Yeah, you use a filter. Do you use a filter?
Yes.
Or you just shake it or agitate it?
This is another version of the lipogem. Lipogem is like the bead, like this way, but micronized fat is like the shaver shaver knife, and then go grind your fat like this way. Yeah, like the mixer, and then pouring the cell line to remove all of the waste product, like the fat particle and other things, and you can get the stem cells and your nutritional things.
Okay, that's good. Great. Dr. Yon, that was a very nice lecture. So any other questions? So we appreciate Dr. Yon for such a wonderful lecture today on the ankle and foot interventional. And I hope you learned something today. And we appreciate Dr. Yon for his time. I know he's very busy. Can you imagine? He had a lecture at 3 a.m. this morning. So I think he almost lose sleep the whole time. But he finds time coming over here to join us in our Zoom meeting. So thank you, Dr. Yon. And hopefully we can join you in some other meetings in the future. And we appreciate everyone for coming. And tomorrow I would like to invite you to another lecture, same time with Dr. Summer Narozi. So everybody is also invited. So thank you again, Dr. Yon. And we appreciate you for all your help today.
My pleasure. Thank you very much.
Yeah, God bless. And have a great day.